Imaging strategy on rectal CA. So it is the fourth most common malignancy in men, third in women. This is the statistics from 5 continents. The incidence in India, I mean this probably this reference is few years old. It is 4.1 in every 1 lakh individual, while it is 59 in Czech Republic. Now, in the newly developed countries, no, the developing countries, the risk is increasing, probably more of screening. Now, for treating colorectal CA, a multidisciplinary team is required, of which radiologist is an important component. There is a study in 2006 which they demonstrated that if you treat a rectal CA without discussion in the multidisciplinary team, the rate of recurrence are higher. Now, rectal CA tumor within 15 centimeters from the anal verge. This is a normal anatomy. This is the anorectal junction. On MR, we define it with a puborectalis sling, which you can see here. This corresponds to the dentate line, what surgeons see. This is the perirectal fat, and the outer black line is the perirectal fascia. Now, why local staging is important? Because the prognosis is directly related to the extramural spread into the mesorectum and the surgeon's ability to achieve surgical clearance at the circumferential resection margin. This I will discuss later. So surgeons, just by finger examination, they cannot decide on the rectal CA treatment. So they have to go to a team for a optimal management. So this is an example of local recurrence, and this is a profound influence on the quality of life. And this study shows that incomplete removal of the lateral spread is the cause of the majority of recurrences. So MR is important in defining the best treatment strategy. Now the imaging option is evaluation of the rectal walls by either endoluminal ultrasound or endoluminal MR. Here I would say ultrasound is a wider available and a good modality. For loco-regional staging, MR would be great from T2 to T4 and N0 to N2. And when it comes to distant metastasis, CT scan or a CT PET will take over. Now, FDG PET is great for distant metastatic disease, and as well as selecting the patient who will respond, who are responding to the chemoradiation therapy and evaluation of local recurrence in the follow-up. Now, this is a patient, this is the pre-therapy scan, this is the post-therapy scan. On PET CT, like we measure HU, they measure the SU value. So, higher the SUV value, the brighter the lesion looks. So, this is the pre-high SUV value, and post-chemotherapy, the SU value decreases. So, this patient is a responder. Now, compared to MRI, MRI is very useful for predicting the T and N categories, while FDG PET is helpful in predicting the pathological complete response after therapy and finding metastasis. Maybe diffusion is now coming up, will compete with FDG PET on these issues. Now versus endo ultrasound, for the T1 and T2 it is very accurate, more than 90%, and this would be the imaging modality of choice. Now when T2 goes to subtle T3, again endo US may do better, but then it has poor accuracy in bulky T3 and advanced rectal CA, and this is where the treatment strategy changes. I have given these references, but there are many references which say the sono is better. Recently there is a reference where they say a combination of CT scan and endosono gives equal or better results. But this varies from institution to institution. Now, if we compare endo ultrasound with a phased array coil, now you can say matrix coil, the accuracy for T staging is 67 to 83%, 100% for T4, and MR is highly accurate in prediction in the circumferential resection margin, which I think it will score over ultrasound. And in this study, by doing MR, they reduce their incomplete resections by 50%. The same slide as in the pelvic imaging I used. Now rectal distension, this is by 3D space. This is an optional thing. You can use rectal distension, but there are articles pro and cons for them because circumferential resection margin is measuring the tumor up to the circumferential resection, the perirectal fascia. Some people say by distending you are reducing that diameter and it will affect. But I think if the tumor is little higher, this helps. Plus, I think it gives an understanding to the surgeon. And the feedback I got from the surgeon that he could explain it easily to the patient by showing these images. Because nowadays patient wants to see, they want to know what is happening. That was the same thing. Then starting with a large FOV, T2 weighted 5 mm, T2 weighted SAG, T1 diffusion,